Antiseptics and Antimicrobials in Periodontology. There is no substitute for a high standard of mechanical plaque control. Evaluation of antimicrobial agents. Several basic criteria must be discussed when considering a chemical plaque control agent. 1. Specificity. Antimicrobial substances, reserved for the treatment of serious medical infections, must as a rule not be used to control plaque locally. Systemically administered antibiotics may be used in rare situations in patients with severe forms of periodontal disease, but only after an accurate microbiological diagnosis. 2. Efficacy. The antimicrobial agent selected must be effective against microorganisms implicated in the etiology of gingivitis and periodontitis. 3. Substantivity is a measure of the contact time that connects a substance and substrate in a given medium. In treating dental plaque infections, the substantivity of the antimicrobial agent is of the utmost importance, since the agent needs a certain amount of contact time in order to inhibit or kill a microorganism. Aims of anti-plaque agents: should inhibit microbial colonization of the tooth surface and the subsequent development of plaque. Should eliminate plaque already present by dissolution or alteration to form a less pathogenic plaque. Should inhibit the calcification of plaque to form calculus. To date, no single agent satisfies totally this criteria. Limitations of existing preparations. Many only have a transient effect whilst they are in the mouth. Some are of insufficient concentration to kill bacteria, and if their concentration is increased to do so, they damage the epithelial cells. Mouthwashes are only of use on supragingival plaque and therefore for preventing and controlling gingivitis in risk patients, e.g. post-surgery, the handicapped, certain oral mucosal conditions, erosive/ulcerative, and prior to ultrasonic scaling. Enzyme preparations: 1. First-generation compounds. 2. Second-generation compounds. First-generation compounds: 1. Antibiotics. 2. Phenols. 3. QUACs, quaternary ammonium compounds. 4. Sanguinarine. First-generation compounds reduce plaque scores by 20 to 50%. Second-generation compounds: 1. Bisguanides, e.g. chlorhexidine gluconate. Some common examples: 1. Phenol-based preparations: Listerine, contains thymol, eucalyptol, methyl salicylate, benzoic acid and boric acid in a strongly hydroalcoholic vehicle. Shown clinically to reduce plaque scores by 20% and gingivitis scores by 30%. Thought to reduce plaque pathogenicity by reducing its endotoxin activity. 2. QUACs. Cetylpyridinium chloride appears to be an effective inhibitor of plaque formation, however not as effective as chlorhexidine. Does not stain teeth. 3. Bisguanides. Chlorhexidine gluconate, the most effective anti-plaque family and the main second-generation anti-plaque agents. Synthesis by ICI. Chlorhexidine data. Purely topical action, doesn't penetrate oral mucosa. Poor systemic absorption and relatively safe. Levels of up to 0.2% are tolerated by the eye and safe to skin. The most effective anti-plaque agent to date. Binds to acidic protein groups, e.g. phosphates, sulfates, carboxyl-ions. These are present in the salivary glycoproteins that comprise plaque pellicle. The CXD adsorbs to epithelium and tooth surface. May also bind to bacterial capsules, polysaccharide in nature, and therefore reduce bacterial binding to tooth tissue. After 1 minute rinse with 0.2% CXD, 10 mls, 30% of drug is retained. Ca2+ ions and detergents reduce oral binding, and as they are present in toothpastes, do not use toothpastes immediately before or after CXD use. In the absence of other oral hygiene measures, reduces oral bacterial count by 85 to 90%. The minimum concentration of CXD required to be effective as a plaque inhibitor is 0.12%. The minimum time for which CXD should be kept in oral cavity during rinsing, for the effective plaque control, is 30 seconds. Unwanted effects of chlorhexidine. Extrinsic staining of the teeth. Desquamative gingivitis. A type of hypersensitivity to CXD in rare cases leads to painful erosions of the gingiva and a burning sensation. Altered taste sensation to salty tastes, is a short-term complication only. Reports of parotid swelling are rare and easily reversible following exclusion of its use. Uses of chlorhexidine. In the short term following gingival, periodontal or oral surgery. Long-term use in patients whose mechanical plaque control is severely impaired, e.g. fixed orthodontic appliances. In handicapped patients as an adjunct to mechanical cleaning, can apply gel in a soft splint. As an aid in the management of drug-induced gingival overgrowth. Ulcerative gingival conditions, e.g. aphthous ulceration. Periodontal pocket irrigation. Shown to be effective in reducing bacterial levels within periodontal pockets. Brand names: 1 Corcidil, 0.2%. 2 Aludril, 0.2%. 4 Metallic salts. Zinc salts, good evidence for anti-plaque and calculus properties of zinc salts of 0.2 to 4%. Zinc citrate and triclosan combined in a toothpaste have been shown to be more effective than either alone. Tin salts, SNF2-based mouth rinses shown to be very effective but weaker than CXD. 5 Sanguinarin. This is an alkaloid derivative obtained from a plant. In its quaternary ammonium form, can inhibit the growth of several putative periodontopathogens. It is retained in dental plaque. Significant anti-plaque properties but low compared to CXD. 6 PLAX. Active ingredients for plaques are sodium borate and sodium lauryl sulfate. Teeth feel slick because of the glycerin in the formula. 7 Hexetidine, Oraldine. Effective, but less so than chlorhexidine. Does not stain but may cause hypersensitivity reaction. Antibiotics in the management of periodontal disease. Indications for use, in NG, following scaling. May be indicated in the management of HIVP. Consult patient's specialist. As an antibiotic prophylaxis. In multiple abscess formation with diabetes. In regenerative technique. Routes of administration. Systemically traditional method. Local delivery systems promising research results and possibly where the future lies. Preferred drugs. 1 The tetracyclines. Bacteriostatic, e.g. oxytetracycline 250 mg QDS. Levels in GCF reach 2 to 3 times serum levels. Do not use with impaired renal function. Minocycline or doxycycline, achieves 5 to 10x serum levels. It is also a safe drug with renal compromised. Dose 100 mg BD. Finally, the tetracyclines chelate calcium ions, and the latter are essential for certain metalloproteinases, e.g. collagenase, to function. Since the latter are involved in the destruction of the periodontal tissues, these drugs have an additional benefit. 2 Metronidazole, Flagyl, does also appear in GCF 50% higher levels than in serum. Effective against anaerobes and dosage is 250 mg TDS up to 500 mg TDS. Avoid in pregnancy. The drug of choice for NG. 3 Augmentin, 250 mg amoxicillin and 125 mg clavulanic acid, TDS. Clavulanic acid is a blacktopus inhibitor and therefore acts against organisms that are resistant to penicillin. Modulation of the host response in periodontal therapy. Until recently, treatment strategies for periodontal disease were primarily based on the understanding that plaque bacteria and their products mediated the tissue destruction in periodontal patients. This concept began to change, however, when investigators reported that host responses to the causative bacteria were a major contributor to disease pathogenesis. With a new understanding of host response and periodontal disease pathogenesis, it became apparent that inhibition of certain host response pathways might be an additional strategy, in addition to suppressing the causative bacteria, for treating periodontal diseases. The current understanding of periodontal disease etiology and pathogenesis emphasizes the role of the host in tissue destruction.